tinnitus treatment. Tinnitus is something that many clinicians have a difficult time with. Hopefully today I'm here to show you that tinnitus treatment can be rewarding and is a very important task for an audiologist to take on. I have been involved in tinnitus product development at Oticon. Prior to that, I was an audiologist sitting out and fitting hearing aids, working with tinnitus, like some of you. So for those of you who need a reminder as to what tinnitus is, it is the perception of sounds which are not produced from an outside source. So it's a sound that you hear inside your head, no one else can hear. It's an auditory perception, and it's generated somewhere in the auditory system. It could be the ear, the auditory nerve, somewhere in the brain. There's still a lot of debate about where tinnitus comes from, what causes it. Probably because it's not a black and white thing. Can we treat tinnitus? Well, no. There's no pill you can take or surgery you can take to make tinnitus go away. But just because we don't have a cure for tinnitus, it doesn't mean there's nothing we can do. A lot of patients have stories of going to the doctor or going to an audiologist years ago and having heard, "I'm sorry, there's nothing I can do to help you." Well, that should no longer be the case. There's lots we can do to help people with tinnitus. So there's many different tinnitus approaches to treatment. And there's probably some confusion because there's so many ways to work with tinnitus. But the general rule is that if the patient benefits from the treatment, then the method is effective. So the goal is to figure out which method works best for you. It's also important to choose a method which is evidence-based. We want to make sure that the research backs up the approach that we use. Hearing aids are a very evidence-based treatment path for tinnitus. It's typically not a treatment in itself, but it's part of many other treatments. Tinnitus masking is an approach that started in the 1970s with Jack Vernon, and it was the first attempt at a methodical way to treat tinnitus. The main premise is that you use a relief sound that could be broadband noise, like white noise or pink noise, or water, could be any type of sound, and that you cover the tinnitus up with that sound. So you add the sound in a hearing aid or a device, and that way it blocks you from hearing your own tinnitus. The goal is to completely block the tinnitus, so all you're hearing is the relief sound. There's neuromonics tinnitus treatment. This is a method that's also been very popular in later years. It's basically typically a 6-month treatment where you listen to sounds 1 to 2 hours a day. So it's quite a commitment, this type of treatment. And it allows your brain to get used to hearing different sounds. TRT, or tinnitus retraining therapy. This is a big one, and I'm going to talk a lot about this one today. It's a method that started back in the 1990s, and it's very well used, broadly used in the whole world today. We have progressive tinnitus management, or called PTM, and these two are the ones that I'm going to talk about most. And lastly, cognitive behavioral therapy. This is traditionally thought of as a psychological approach. The psychologist goes in and treats the patient, not the audiologist. And it's also part of many different approaches, just like hearing aids are. So what do most approaches to treatment have in common? Well, counseling is a big thing. Without counseling, you're not teaching the patient how to manage their tinnitus in the best possible way. Amplification and sound therapy, using other sounds to help your own sound seem less important. Relaxation, stress management. It's well known that anxiety and stress can make tinnitus worse. So learning methods to help you manage your stress is very important. And lastly, sleep management. People with tinnitus, they can't sleep very well. They might get by during the day, but when they lay down on their pillow at night, they can't sleep. So working on that is important too. So these are the two approaches we're going to talk about today. The neurophysiologically based model, that's TRT, the tinnitus retraining therapy. And then we have the clinical pathway model, which is progressive tinnitus management. I drew a little picture here because TRT is a brain model. It basically is based on the fact that tinnitus is not an ear problem, it's a brain issue. And the PTM is a clinical model. It's a way to use treatment in steps. I'm going to start talking about TRT first. So tinnitus retraining therapy all started with Pavel Jastrabov. He's if you know one name in tinnitus, it's probably his. Back in 1990, he came out with a landmark study, or a paper, where he described what he thought was the best theory of why tinnitus exists and why it gets worse and worse. In 1999, he officially coined the term tinnitus retraining therapy, which is what we also use today. The reason I talk about neurophysiology here is because his training is entirely based on you understanding what's going on in the brain. So this is his model of tinnitus, and I like to explain this model in a more simplified version. This is what it looks like. It's an adaptation by McKenna, Bagley, and McFerrin, and it has 5 boxes. Starts at the ear and auditory nerve, and then we go up to the brain, and the limbic system, which is your emotional brain, and the autonomic nervous system, which is your physical reactions, the bodily reactions to different things. So I would like to explain these terms using an example. Let's take this one first, a baby laughing. Now, this is a sound that makes many of us feel happy. It's hard to look at this baby and not smile or think, that's a nice sound, hearing a baby laugh. Now, your ear picks up the sound and it converts it to electrical signals that are sent up through your auditory nerve to your brain. Here, your brain filters out this baby laugh sound, recognizes it. Let's say it's your baby. You recognize your baby. You become aware, my baby's laughing. And then your limbic system has a reaction. You have an emotional reaction to this sound. In this case, it's joy, pleasure. You may also have a physical response, a body reaction to this sound. You may relax because you know your child is happy, or you may get excited on their behalf. Now, let's imagine you're hiking in the jungle. Different example. You hear this. Now, if you're like me, you don't like snakes. I hate snakes. I'm very scared of them. And if I'm hiking through the jungle and I hear a snake over my shoulder, I'm going to have a very different reaction to a sound. So in this case, the ear picks up the sound, it's sent up to the brain, I recognize it. I become consciously aware that I'm hearing a poisonous snake hissing in my ear. Now, my emotional response is panic. I might be scared. And my autonomic nervous system reacts with what we call the fight or flight response. Either I'm going to stay there and deal with that snake, or I'm going to run away. So it's a very normal part of our system. This is a naturally occurring behavior that our brain responds to sound depending on what it is. Happy sounds, scary sounds, or whatever sound. Now, your auditory system will also sometimes send sounds up to the brain when there's no sound in your environment. So these little electrical nerve pulses will be sent up to the brain even though there's no sound. So what happens in this case? Your brain says, oh, this is not an important sound. I don't need to hear it. I don't need to be aware of it. It's not dangerous to me, it's just there. So you never become consciously aware of it, you don't have an emotional response to it, and you don't have a bodily response to this sound. This random electrical activity is what we think tinnitus is. Now, back to tinnitus. So in a person who has tinnitus, what goes wrong? The part of your brain that's supposed to filter out that sound and say, it's not important, is not functioning as it should. So you're hearing this sound. You're hearing the tinnitus. You're aware of it. You might be concerned. If you've been having tinnitus for a while, you might be depressed or anxious. You might have a very strong reaction to the sound. A lot of arrows here. Basically, this is just to say that all these systems talk to each other. So when a response happens in one system, it affects the other systems as well. I've been part of developing some counseling materials because I think these concepts are extremely important to explain to a patient with tinnitus. This is not something you're making up. This is actually happening. And your responses to this sound are affecting how you hear it. So this is what I would say to a patient in a clinic, and this is the material that I've helped develop. We use the example of a faucet, and it's dripping. You're in bed at night, you hear that dripping sound, you become aware of it. It's not supposed to be there. It annoys you. You may have that negative response to it. Maybe you have to get up in the morning, and this sound is preventing you from falling asleep. Your heart starts pounding. Maybe your palms get sweaty. Maybe you get nervous. You focus even more on that sound. And so the drip that started as a little drip gets bigger and bigger and bigger. And it cycles around and becomes worse and worse. So what is tinnitus retraining therapy? It's basically a way to break this negative cycle, to get out of it, so you're not constantly making it worse yourself. The goal of TRT is to remove the negative emotions and reactions that you have to tinnitus. You don't want to have a positive reaction to tinnitus. You want no reaction to tinnitus. You want it to be habituated. Jastreboff calls this habituation of reaction. You don't have a reaction to the sound. Getting used to the sound, habituation of perception. How long does this take? Generally, Jastreboff talks about 12 to 24 months, but you'll see results typically within the first month. So you might be wondering, well, what's habituation? This is a term that's used a lot in TRT. It's basically the disappearance of a reaction to a stimulus, or in other words, you get used to it. You get used to the sound. So Dr. Richard Tyler, he's another prominent tinnitus researcher, and I really like his picture of how to explain habituation. He uses this with his patients in the clinic, and he talks about when you buy a refrigerator and you take it home, you install it in your kitchen, and you hear the humming sound of the refrigerator. it's very apparent to you. 2 weeks go by, you're hearing that fridge every day. It's not as much. You hear it maybe a little bit. A month goes by, you never think about it again. It's just there. That's habituation. That's what we want to train patients to do with their tinnitus. TRT includes 3 main basic elements. We have the patient education and counseling, which also includes stress and sleep management, sound therapy, and hearing instruments, or what we call a combination device. To those of you who don't know what a combination device is, it looks like a hearing aid. You wear it on your ear. It is a hearing aid. It amplifies sound, but it also has the ability to play a sound, white noise, pink noise, maybe even an ocean sound, a nature sound, to help you take your focus off the tinnitus. For some patients, hearing aids are enough. And for other patients, a combination device can be a great tool to help them habituate to their tinnitus sound. So sound therapy, let's talk a little bit more about that. Jastreboff's way to describe it is, if we start up here, you have along the y-axis your signal, the x-axis is your frequency response from low to high frequencies. There's the tinnitus signal, in this case a high-pitched squeal, and on a background of just random background noise. Now let's say we increase that background noise to a much higher level. Now, look, the distance between the background noise and the tinnitus signal is much less. We still hear it, we're supposed to, but it's not as noticeable. The way to explain this in the clinic, I like Grant Searchfield's picture here. You have a cricket on the right. You see the cricket, you know there's something in the background, but all you can really focus on is that cricket. Well, notice the background now. You add in a few rocks and water and trees. Now you really have to look to see that cricket. That's what we want to do with the tinnitus sound. This is the example that we use. A violin in a quiet room, it's all you focus on. You add in other instruments, now it's just part of something bigger. It's not a big deal. There are some recommendations that TRT has as far as hearing aids are concerned. You don't want to mask all the time, meaning you don't want to cover up the tinnitus completely all the time. Because if you cover it up, how can you get used to it? You never hear it. When you turn off the tinnitus sound, or the relief sound, I should say, then the tinnitus is back right where it was. So even though masking, complete masking like this can be good in some circumstances, most of the time you don't want to do that. You want a hearing instrument that has a wide bandwidth, meaning it amplifies from very low to pretty high frequencies, as high as you can get. So when you're doing tinnitus treatment, you want to look for hearing aids that have a wide bandwidth. That's because for some patients, their tinnitus sound is very high pitched, and they want a hearing aid or a combination device that can cover up their tinnitus pitch. That's hard to do if your hearing instrument only goes out to 5 kilohertz. You always want to fit binaurally. This came as a bit of a surprise to me when I was learning about this, especially for people with normal hearing. People with normal hearing have tinnitus too. Sometimes it's an even bigger problem because people don't really recognize that they have a problem. So if one ear is normal hearing and no tinnitus, and the other ear has tinnitus, basically TRT says fit them both. And the reason is your tinnitus can transfer. So if you treat it in one ear, a month or two can go by and you can have tinnitus in the other ear. So it's not always, you can't fix monoraurally. Hyperacusis should always be treated before tinnitus. So hyperacusis, that's the sensitivity to loud sounds. Well, if you're saying, use sounds to help your tinnitus through sound therapy, this is difficult to do if the person can't tolerate sounds that are louder. So you want to treat hyperacusis before you treat tinnitus. Basically, you also want to make sure that the relief sound you're using, the white noise or the pink noise or whatever, is loud enough. You want it to be above the person's threshold, 6 to 20 decibels above their hearing threshold. That's a good thing to keep in mind when fitting hearing aids. Do not fall asleep to pattern sound. So sounds that are very modulated are great during the day, but at night when you're falling asleep, you should have something that's more steady. So there have been some studies done on the evidence for TRT versus, for example, tinnitus masking. So habituating to sound versus covering it up. All these researchers, they're not working against each other. It's not my treatment's better than yours. There's a lot of overlap, and they also work together to do studies to determine the efficacy of different studies. So in this case, TRT, they basically compared TRT versus tinnitus masking for a group who had a moderate tinnitus problem versus a really big tinnitus problem. And what they found was, for moderate problems, the two therapies were actually identical. They both did well. But when a person has a really big tinnitus problem, TRT did quite a bit better. And in this case, you want to look at the score going down. They did the tinnitus handicap inventory, which is a very popular questionnaire to use in tinnitus. And you want that score to go down as far as you can. In this case, it was significantly better than the one for tinnitus masking. This was done across 18 months, an 18-month time span. So just a few key points about TRT. Tinnitus is a brain issue. It's not an ear issue. And that's what the neurophysiological model explains. This is kind of a long sentence, but it's important. Tinnitus retraining therapy is retraining the connections from your auditory system to other brain systems in order to habituate to those negative reactions, so you don't have the negative reactions anymore. This is done through habituation of reaction and habituation of perception. If you can have a normal reaction or no reaction to tinnitus, it'll affect habituation of perception. You will no longer perceive it as being as loud either. The etiology of tinnitus, so the cause of tinnitus, is irrelevant. This is not something we hear a lot in a medical setting, but TRT focuses on the reaction to the tinnitus. We're not trying to remove the tinnitus itself. We know we can't do that. So we're just trying to focus on the reaction. So no matter what the patient says caused it, you can still treat using TRT. Avoid silence. As many sounds as possible is better. And don't overprotect hearing. Normally we want to protect our patient's hearing, and you still want to do that, but you don't want someone to constantly be wearing ear protection. It's going to work against your treatment. You're changing the negative brain reflex to sound. You want to change it to a reflex that's not negative. And you don't want to have too many clinic visits. If you have a patient coming in every week for their tinnitus, they're always thinking about it. You want them to not think about it, not focus on it so much. So even though many visits might help counseling-wise, you can talk a lot more, you might be able to incorporate more cognitive behavioral therapy. Too many visits can work against you. Masking, complete masking, use it temporarily. It doesn't allow you to habituate, so it's only what we call a short-term solution. TRT is meant to be a long-term solution. If you look at studies that have tested this, you'll see at 3 to 5 years, the effects of TRT are actually still there. Above all, the relief sound you're using must not be annoying. So patients can have very different experiences of what sounds good and what's annoying. So finding the right sound for them is crucial to them listening to the sound and getting better. And don't forget, the patient is the partner in treatment. They are doing part of the work. Without them doing work for themselves, you're not going to be very effective. So let's talk about progressive tinnitus management a little bit. It's basically it's a treatment developed by James Henry and his research collaborators in 2005. And he works at the Department of Veterans Affairs in the U.S. The Department of Veterans Affairs takes care of all the veterans of war who come back and need all kinds of treatment. A lot of them have noise-induced hearing loss, and a lot of them have tinnitus. So they felt the need to develop their own protocol that was cost-effective and worked well for their patient group. So they use elements of TRT, they use masking, they use cognitive behavioral therapy, they use hearing aids, they use all these things in the way that works best that they think. The purpose is to teach patients how to manage their negative reactions to tinnitus, sounds a lot like TRT, and this will lead to an improved quality of life. Goal, self-efficacy of tinnitus management. You do the work. The patient does the work, not the clinician. And teaching them that it's their responsibility is a big part of PTM. How? Either through individual or group therapy, sound therapy, or counseling, all three. So we have about 10 to 15% of the population, adult population, pretty much in the world, who has tinnitus. Of these 10, 15%, about 80% of them, they have it, but it doesn't bother them. So this isn't the group that we generally deal too much with. The group that we deal with the most is the 20% who have bothersome tinnitus. They seek help. They're having issues. And then you have the debilitating tinnitus, the 1 to 2% that are having a really difficult time, to the point that they may be severely depressed, very severe anxiety, lots of other issues going on. This might not be the first patients you want to treat going into tinnitus treatment. I'm not going to talk in detail about this, but I just wanted to show you as a model of tinnitus treatment. PTM has these 5 levels. First level, referring to the right place, referring to the ENT, the audiologist, psychologist. 2, an audiological evaluation. That's the hearing test. This is also where you typically get hearing aids and where you assess how bad is the tinnitus. So as you can see out here, this is typically the 80% go through this part. Now, if you have worse tinnitus, you move up to group 3. This is a group education exercise. It's about 5 weeks long. You have group classes and you learn skills to help you cope. You may already have hearing aids at this point, or you may not. You develop what we call a sound plan. I'll talk to you a little bit more about that. And you also learn about stress management, relaxation exercises, all that stuff. If you need more help, you have appointments with the audiologist and psychologist. You might get fitted with a combination device, TSG, tinnitus sound generator. That's a combination device. We might start measuring the psychoacoustic measures. What is the pitch of your tinnitus? How loud is it? Tinnitus pitch and loudness matching. And then individualized support. Very few actually make it up to the top. A lot of people can be treated down here. And the reason this is a great way to do it is because it's very cost effective. You can treat patients in groups at the same time, and they can help each other too, which it's a lot about group support. Self-management. I mentioned this a little bit earlier, but basically you want to teach them strategies for managing tinnitus, use of sounds, talked a little bit about that already. They modeled their approach after chronic pain management. There's some similarities there because you can't make it go away, but you can change your reaction to it, and so they've borrowed a lot from the research on chronic pain. The patient makes an active effort. You don't just passively receive treatment. They talk about a shift in responsibility from the professional to the patient. It's your tinnitus, it's your responsibility. I'm going to help you through it. You're not alone, but you're the one who has to do this. One of the ways they do this is through sound therapy. There's that word again. As you can tell, this is an important part of most treatment plans. The picture they use, I just like it. Candle in the dark, all you can see. You flip the light on, now you see the whole room. It's just a way of showing you add more sound, and you can no longer notice your tinnitus as much. They also divide sounds into sound types. Generally, it's these three: soothing, background sounds, and interesting sounds. And you have a bunch of different, all the sounds in the world can be divided basically into these three categories. The exercise for the patient is to figure out which sounds work best in what environment, very specifically. When I go to sleep, I want to hear a soothing sound. A soothing sound for me is hearing jungle rain. Or when I go out into, I have a meeting at work, this might be a situation where I like hearing a little bit of pink noise. It helps me focus. And this is just how they show it in their literature. Interesting sounds, I just want to mention, that could be podcasts, could be music, could be talking to other people, could be anything. It doesn't have to be a difficult exercise. You just have to start thinking about it. You make a sound plan. Every patient does this in the level 3 stage. They basically have to determine which sounds help for them and check it off, and a week later or 2 weeks later, they determine how much it helped, or if it didn't help, maybe I should try something else. There's also recommendations for hearing instruments here. Something I think is important to mention is that the recommendations we traditionally have for hearing loss, amplifying for hearing loss, are not always the same for tinnitus management. One of the recommendations, and this isn't just PTM, this is in general, open fit hearing instruments, keeping the ear open, allowing access to environmental sound naturally into the ear. It's very important for this type of management. But that's not always the best for hearing loss. If someone has a flat hearing loss and need low frequency amplification, an open fit hearing instrument might not be the best fit for them, but it might be better for their tinnitus. Hearing instruments with feedback elimination circuitry. You want feedbacks that don't squeal even though they're open fit, so you want them to have a good feedback system. Noise reduction circuitry is turned off or reduced. When we talk hearing aids, we often talk about the importance of having good noise reduction, especially in noisy environments or challenging listening environments. In this case, some of these researchers say, nope, you don't want it on at all. You want them to hear as much sound as possible. They're not always going to be comfortable with that, but trying to find that balance, that's the clinician's job. You always want to use hearing aids, instruments, or combination devices if the patient is willing, if it's a situation where it is appropriate. And as far as the hearing aids are concerned, they're basically, the reason you want to use them is because it increases all the information available to the patient. You want to amplify the background sound, but also because being able to communicate better reduces stress. So just a quick study as evidence for PTM group counseling. Henry and research partners in 2007 by the way, they have ongoing research all the time, so it's always interesting to go in and see what they're currently working on. But they divided a large group of patients into 3 groups. One that received no treatment at all, one that received hearing aids, traditional support, but no specific tinnitus treatment counseling, and the last group that had educational counseling, the full package, TRT based. They were tested over the course of 12 months, and the conclusion was that the educational counseling was significantly better than no treatment, but also better than traditional counseling. And this was for patients who had clinically significant tinnitus, not just little, significant amount. So it shows us that group counseling can be effective. You don't have to be one-on-one. I put this up here because progressive tinnitus management, it's just it's a really nice setup, and they have a bunch of materials out there that are available for anyone to go in and look at. I encourage you to check out this website, but also they have books, DVDs, CDs, a lot of stuff that you can use if you're interested in seeing how this approach is done. Just quickly here, how do you know if your treatment works? This is important, always. I have some personal experience with this because I didn't realize how important it was to measure before and after in tinnitus. We know with hearing aids, real ear measurements, other validation measurements you can do, but what do you do for tinnitus? In this case, the tinnitus handicap inventory is the best tool you can have. It measures the severity of a person's tinnitus from very mild or no handicap to catastrophic handicap and puts them in a category. The reason that this is helpful, there's many reasons, but basically it helps you determine how severe is this? Is this non-bothersome tinnitus or is it bothersome tinnitus? Right there you might know where to start, what to talk to your patients about. Do I need to refer this patient? If they have catastrophic results on this test, maybe they need to go see a psychologist or a counselor first. It allows you to see if your treatment is working. You basically would do a test before and after you've talked to them and see how their numbers have changed. It's a great counseling tool. This is an important one because tinnitus is not measurable in a lot of ways. And patients love having a way to see my tinnitus changed. My perception of my tinnitus changed. I had an 84, now I have a 55. This is great, I can measure this difference. I know it got better, and that affects them in a positive way going forward. It's very quick, it's easy to use, but you can also help determine which areas are difficult for the patient and which are not, and counsel in regards to that. It's your best friend in treatment. I highly recommend using it. I didn't make it or anything, but it's freely available for anyone to use. My personal example of this, basically how I used to use it in the clinic, you have a first consultation for tinnitus, you discuss the difficulties they have, and you help the patient fill it out. So you ask the questions, you write down the responses. This takes a little bit longer, about 10 minutes or so. Then you score it, and you move on. When they come back, they read it, they score it, they fill it out themselves. In the meantime, you might be hooking up hearing instruments or doing whatever else you need to prep for your appointment. So it doesn't have to be something that takes a long time. And you can counsel based on the score. You can repeat this test, and I would encourage clinicians working with tinnitus to do so in a month, 3 months, 6 months, 12 months. So you can mark, maybe also if your treatment stopped working for a while, did something change? Did their reactions to tinnitus change? Do you need to go back a step? So just a few things to remember before we stop. There's no cure for tinnitus, but we can remove the reaction to tinnitus. So if you remember one thing, that's it right there. TRT and PTM are validated and they're high quality approaches to tinnitus management. Even if you don't go use TRT specifically, I would consider using the 5 elements from the beginning of my presentation. You want to have amplification, counseling, relaxation, sleep management, and sound therapy. If you have those elements, you're good to go. And one of the things we often hear is audiologists or people working with hearing loss, they say, well, I'm not a psychologist, how can I do psychological counseling? Well, you don't do cognitive behavioral therapy per se, but you do elements of it every day. Every time you have a patient in the clinic, you're talking to them about how to manage, how to cope, how are they doing, and talking to them. This is counseling. So audiologists and related fields are excellent counselors. You should use this as a big plus in tinnitus management. And use the questionnaires. It's a very rewarding process for the patient, but also for the professional, if you find your own way to do this that works in your setting. I want to thank you for having me here today.